Hello. Hello, everyone, and welcome to the IDL talk for today, which is Thursday, January the 30th. And this is part of our ongoing Informatics Discovery Lab talk schedule. And today with us we have Thanh Tran. It's my pleasure to introduce him to you. He's the CEO and co-founder of Zoeticx Incorporated, which is a startup software company in the mobile health universe. And prior to Zoeticx, Thanh was Chief Technology Officer of Amdocs Limited, which provides software and services for the telecommunication industry, especially billing services for telecommunications. So if you ever received a really weird bill from your cell phone carrier, Thanh is responsible for that. And prior to Amdocs, he was Senior Vice President and General Manager for BEA Systems and was involved in providing service-oriented architecture solutions. But somewhere along the line from this pure technology background, Thanh had an epiphany and ended up creating a healthcare solution that he's going to talk to us about today. He has a number of patents and innovations to his name. He's been honored for with industry awards for his work, but I think the passion that drives him today is developing this product at Zoeticx. And today he will be talking about Zoeticx and specifically how the application developed by Zoeticx can help clinicians by extending the functionality of the electronic health record. And now we actually live stream our talks. So for those of you who are in cyberspace, I say welcome. It is raining here in Portland, Oregon. I'm going to turn it over to Brett for 1 second. He's going to give those folks in cyberspace the opportunity to ask questions through Twitter. And then we'll turn it over to Thanh for the lecture today. Thank you.
So for those following the live stream around the world, you can follow the conversation on Twitter through our handle at OHSU Informatics and submit questions using the hashtag DMICEConf. That's DMICECONF. Thank you.
So, hi everybody, thank you for coming. One thing I would like to go through a few disclaimers before I start. First of all, I'm not a doctor. I'm a pure IT. My career up to the point that I co-found Zoeticx is all IT. I'm doing a lot of manufacturing, finance, you name it. And then don't know what happened after I left Amdocs. I decided to do something totally different. And I get into IT. And we form a set of team that have a number of medical advisors who give us and trying to train us to be doctor. But at the same time, my talk today will be very focused on how we bring the IT advancement from the other vertical and trying to see how it can help healthcare in general. Okay? So I will jump into, I'm not going to go spend a lot of time in healthcare challenge. I'm going to be browse through the set of problems that we're going to solve with our care product suite, and then we do a live demo. And then I'm going to spend some time on the platform, the collaborative platform that we have. We're trying to reserve at least 25 minutes per question. Okay? So we take this thing from JEMA, and basically it's about what a typical challenge in healthcare would be. I'm not going to read through it, but basically it's about collaboration, about communication, about medical handoff, about quality of care, and above all, if it's closer to the IT world, it's a lot of people talking about the EMR interoperability. Okay? And we see a lot of change. I'm not going to go through all the things that you face at Oregon Health and Science, but those change is coming from this set of four problems. Poor data. So EMR would put moving the paper to paperless, putting the data into an electronic form. But that electronic form, unfortunately, sometimes doesn't reflect what healthcare provider really see in a paper environment. So it's causing some disruption. Bottom line is this. I take the first quote from somebody in this room. right, Vishnu? You know that first code? This is 1,300 data point per ICU per day, and care provider have to go and look for that for the database-oriented EMR system. And then, by the way, this is not just one type of EMR. It's a lot of different EMR that do the same thing. The second set of problem is the communication failure. So collaboration, handoff process is manual. I'm not saying that we don't have a process right now, but it's manual. The goal is to see how IT can turn that environment into somebody to support care provider, not the way around. Alert fatigue. Actually, I was visiting the ICU. It was confirmed. Number one problem at the ICU is say, well, what would make your life easier? Alert fatigue. I get alert all the time. I ignore the alert. Sometimes the alert was incorrect. I'm going to turn them off, and Aaron is my witness. Jeff is my witness too. Third one is EMR complexity. And the area of EMR complexity is also, I don't know about Oregon, but in California, physician doesn't work for the hospital. And physician and care doctor, usually they have to deal with municipal hospital. What if one hospital use Epic, the second one use Cerner, the third one happen to use Osprey? How that doctor is going to go engage and learn all these things. The key things is you make IT support the user, not the other way around. And that is, for me, that's the next problem, that it's kind of increasing. It's coming from the EMR interoperability, but there's a lot of variation of EMR interoperability that's saying, you know, what if two hospital merge? What's going to happen? How you integrate that system? So that's more like an IT talk, but from the care provider point of view, you want all this set of problem is probably say, you want care provider to do patient care, not IT. Okay? So the solution is, number one, you have to turn that data into patient information. You have to get that information to the care provider at the right time. You don't blast them. You don't broadcast to them. You don't tell them all the time and say, now the measurement is 38 degrees Celsius, and then the doctor and the care provider have to look at that. That's a waste of time, but only tell them when you really need it. You need to be able to leverage the technology like cloud, like mobile, right? How I'm going to go, the one thing about the industry is BlackBerry. You know, if you look at BlackBerry, and I'm take this example, is BlackBerry changing our world and say, make every of us work harder without even saying anything. You are everywhere, and your email reach to you, and you get eager to go answer that. Guess what? You're working, right? But then but they do that voluntarily. They do that and as a push system. They push and give that information to you, and then you answer things, right? But you don't feel like this is how you scale up the care provider bandwidth and time, because you only get that information and you'll be able to respond it when you need to, not to everybody. If that message is intended for Jeff, it should go to Jeff. Don't bother me, okay? If it go to me, I answer. But then if I happen to, both Jeff and me happen to look at both emails at the same time, 50% of worth of bandwidth been looked at, okay? Mobility. You want to be able to reach out to care provider anytime, anywhere, okay? And then that is basically saying that if you have a case and there is an alert, and the alert will reach, you don't have to go and chase and call the doctor and things. We have this mobile device. They are smart device. They are capable to handling a lot of data, right? How are you going to get that? How do you get that information to be able to get care provider much more productive in the mobile world? And last but not least is, because I come from the IT and a lot of things, it's kind of like influenced my way of thinking a little bit. Is my job at BEA was I come up with, I'm working in the early days with the service-oriented architecture, and I'm seeing is, you know, in the world of finance, telco, and things like that, you know that mainframe computers still exist some bank. They don't take it away. They bring more value to that piece of data. How do you do that? You're creating a bus, and you expose those data from this bus, and then you'll be able to create new application on the new technology a lot faster. Oracle Fusion have the same problem. When they bought PeopleSoft, they bought Siebel. Guess what? Oracle have a set of CRM application. I'm not going to go to the customer and say, hey, since I bought Siebel, you have to forklift this thing and put that application in order for you to have new feature from us. They're going to kick you out, right? So it's a cost and a disruption to the business. And how do you avoid that? By creating a layer on top of it and then enhance the application on that top layer so that you seal off the legacy behind. Okay? So that's just the way that I see it, healthcare need to do it. You're not going to go and tell a hospital with Epic and the Cerner guy say, go and change that thing and give Cerner, and then therefore I will bring you more feature and things like that. Nobody's going to go and do that disruption. Every time you change an EMR, it takes 2 or 3 years. Okay? So in terms of architecture, before I go into the demo, I basically walk through very quickly on this. The whole idea is at the back here as EMR. Point of care collect those information. The data stay there. Okay? Since this EMR, and I used to use an example, say Epic speak English, Cerner speak Chinese, and how all these things, it store the patient clinical data, it is basically universal. This set of gateway in the back of these things is basically translate that information into universal patient clinical data. Temperature, heart rate are the same. So that gateway is basically do a translator, a mapping, a data mapping. Okay? It brings the data information to the platform, the server, who sit in the cloud, and that server has 2 pieces. Besides normalizing the data, it adding also the message infrastructure that basically I'll be able to say, you can set a rule saying if 20% off normal from temperature, don't go to the doctor. Notify the nurse. Okay? And then be able to follow and make sure that nothing gets fall in the crack. Then we put the front application on the mobile device. Okay? And that mobile device is, right now we started by having that thing on iOS, Apple, and then that's what had happened. And then we're going to talk about the platform in the next few minutes. So I'm going to go and fire up the demo, and basically what I'm going to show you today and walk through, the first one is the dashboard and electronic nurse flow sheet replacement on the mobile. Okay? Then I'm going to go and connect to, via this mobile router that I have, to my cloud server who sits in San Jose, and it's connecting to multiple different EMR systems. I'm going to show you how it switches between of this thing and presenting the same information to the front. I'm going to walk through what the smart alert be, and I'm going to go and show the collaboration piece. The last piece I'm going to show is the ability to saying that I can also federate the data from inpatient and outpatient on the same dashboard and be able to saying that you are in hospital, you have the ICU, and you want to connect it and see what happened, what the family doctor would say. You'll be able to retrieve that information and see, for example, kind of chronic disease or history of that patient without even call and things like that. Okay? So I hope that technology will work. Does it work? So the first thing I'm going to walk through is what the dashboard demo, the dashboard look like this is care intelligence. So this is what we are designing this basing on the nurse flow sheet and the ICU. Okay, so you select the patients and you see right away the trends. of the vital sign. Right now, it has 24 data, but if you have more than 24 data, you can swipe it, and it moves with you. Okay? It's time correlate based, and in look at the trends, you can zoom it, or I have to say this, I give credit where it belongs. This input is from Jeff and Vishnu, that usually that we have to put the hand on to move the things. Now you have this one you can turn on, and you can move the data, and you can see the detail behind the graph and the trends. Okay? Now, as a doctor or care provider, you sometime at the ICU, you look and you say, I want to see what the vital sign along with hemodynamic data. That's how you do it. Or in case of, if I'm an old doctor and I want to see in the line graph, I can have that too. Okay? So is it only hemodynamics? It's medicine, it's IO. And by the way, every time like I move the graph, it all go together. It's time synchronized across. It is basically present information, the trends, and have the eyes and the doctor basically say, I want to zoom in, I want to see why is that temperature going high, and I want to see what the intake output is. Okay? You can also retrieving all the lab informations on that thing, and then it's recorded by the time where the sample is presented, the time where the sample is collected. Okay? Ventilatory and neural information. So basically, at a glance, you have the time data in the last 24 hours, or you want to go and retrieve it back to 5 days, fine. Go ahead, do it, and you can swipe back and forth. Okay? Now you can see that what happened to that little funny teardrop. When a doctor enters a note or documentation, it basically denotes as a teardrop on that graph, and it's showing that you can go and see this Dr. Tom Kennedy is writing something about this patient. Also, at the touch, you can see the patients having when it's admitted and what kind of problem, and you see the allergy and also any procedure that is been. So basically, we're taking the whole 24 hours data or whatever data we can retrieving at time of that visit and present that in a dashboard base. Because this thing on the tablet, we also be able to, it's mobile, so we retrieve it, it's go to the cloud and go to back end EMR. And when you end the session, guess what? Both the cloud and the mobile devices doesn't retain any data. This is real time when you access information, and when I end the session, done. Okay? Now, I also be able to retrieve all the notes, and I can change the date, and you can see the die on the side. Or I can also read all the full medicine or full lab, and then I'm going to show this is the history is when we're connecting to the ambulatory EMR or any other satellite EMR around. So you have two hospitals that dealing with that patient, and you have the agreement to retrieve that and be able to retrieve that information, you can do that also. Okay? Now, the bottom, you can see a lot of like button there. Watch list. The concept of watch list is this. If you have, you can set, and I'm going to show you live, is you can set, say 20% of deviation from the norms, go and inform the nurse. And by the way, don't go to all nurse. Go to that nurse who is active on that shift for that patient. If Terry is a nurse that he's on the previous shift, don't bother him. Please go home sleeping. But it has to go to that because she's an active at that shift for that patient. And she has to take care of it. And if she doesn't acknowledge and do something about it, and when you hit the acknowledge, it will bring the note and say what that can note down and say what she do to address the problem. And if she doesn't do it 3 times, we notify, we push notification to the device that associated with that. If it failed 3 times that she doesn't respond, it go to Jack, the resident. And you can set that thing up. You can set up those things. My point is you can set up all these things at the point of care by the faculty member. It's not like something that you have to call the IT and say, hey, can I do this for this patient and this one? It is under control of the care provider itself. Okay? The second notion is medical documentation or medical order. So medical order is basically associated behind that is a workflow. A lab test will be done multiple steps. Each of the steps have different people who doing that. But we're not going to tell you how you're going to do that step, but we're going to inform you and remind you that, hey, he's a lab technician. I collect the sample already and I send it. So he's going to get a notification and say, it's your turn now. And when he say done, it go back to the care provider to examine the lab result. So all these things is designed to have nothing fall through the crack on the medical order itself. And when you look at the medical order, you can see the medical order itself, or if you have a certain to-do notification, that's how we inform you, say you have to do this because it's on your work list, on your task list. Okay? Okay, so I'm going to go and connect live. I have to make sure that I remember what date the data is. That's my cheat sheet, 7/28. Pardon me? Okay. So what I'm going to do is I'm connecting, and at the end, if you hang around, I can show you that I actually not cheating. The data is coming from the EMR in the back in San Jose, and I can connect to that also. So. So I'm going to go and switch to two EMR. One is this is Open Vista. This is coming from Vista, from the government, from the Veteran Administration. And you can see that this is what is retrieving live right now that goes to San Jose. And in the back of my cloud, there is a simulated, just like you're going to have the simulated Epic. I have a simulated Open Vista. It is actually the Open Vista EMR itself. Okay? Hope it's good. So it retrieves information, and it will present the information, and you can see that I just tap on the patient clinical data and what's going on here. Trust me, it worked this morning. It's still retrieving the data. So this is where we really retrieving from the Open Vista running system in the back. Why is it not? Sorry, just a second.
The nature of it is that when you log in, the notion is that when you log into the system, you log in, it pushes all that data out to the iPad automatically. So it's not doing these constant fetches of data. So you have the overhead of loading that data out only when you first log in.
If you're on the guest network, you have to go to the web browser and then create a
Yeah, you have to do that. It's predicted that it have to have a network connection. And I find out one thing. The truth is when it is connecting with iPad with a telco device and Verizon or AT&T, it works a hell lot better. Okay. This is I'm just switching to OScript, and I talked to you about the ability to retrieve this information from the imagery. So by switching this, you notice that something in the back end is I'm going to the OScript that simulate in my cloud, and then now I'm switching to connecting to a sandbox that actually is in OScript test lab right now. Okay, and then nothing worked for me today. Just a second. It's connected to my little secure thing, so. You know what? Forget about that. I'm going to show you this one, because this one has T-Mobile. Okay. No, it doesn't like it, so it's just a second. Let me. Sorry about that, but the things is it be able to present the information from both, and then I'm trying to get that thing from my independent from the browser here. No, something wrong with the. It could be that the sandbox in OScript is down, but basically what it is you'll be able to tap into that, and then you go to the clinic data EMR. It presents you back all the matching name of that patient on that database, and then the doctor will select and say, I want to see this patient, and then it presenting all the medical history, chronic disease, allergy, what kind of medicine is still active at that time, what is the last visit look like, so that, and in case of the hospital, they can see it and then be able to also not missing any information behind it. Okay? It always. So I want to also share the last piece of information on this piece is this is one of the latest piece of data that we do since this morning is we just finished the porting of the connection to Cerner, and we're able to be retrieving Cerner also. So that information that we can switch to the Cerner EMR and be able to present the Cerner information back. So I'm going to go and try to do that. It's a lot easier because it's just this morning. So I just switched, I'm sorry, I didn't play this thing on the screen properly, but it basically, I just switched to a Cerner EMR in the back. And this is a simulate CMR also back in San Jose. So you notice something, it's the same form factor presenting the information the same way. That's number one. Number two, let me share you one thing. When we do the porting of Cerner, we didn't change a single line of code on this or the server, because the model dictate and deriving everything from there so that you can connect and plug in additional components on it. Okay. So basically, the vision of Zoeticx is a little bit more than just that few application that we have. We look at the things and we look at healthcare in general and say, okay, so is it that 4 application will be the answer to every problem in healthcare? The answer is no. Are we going to be the only one who's going to go and provide all the solution in healthcare? Next answer is no. So the way that we look at it and saying is, if I lay out flat all the And this is not all everybody is dealing with healthcare in general, because you have the hospital, you have the ambulance, you have the clinics, you have the specialists, home care, social network. Your family want to know what's going on with you, and then medical devices, right? So what happened to all these things? Well, it's missing the point that every time that you do something, you have to do a point-to-point connection. What you want to do is create a bus that allow the medical information flow to cross. And I just show you some of the elements that we do with the EMR and be able to create that connection across the board, okay? And how do we do that? Is if I look at the platform a little bit deeper, the first thing we do is, as I was saying, disparate data source. And by the way, I purposely use the term data source because it's not only EMR. Microsoft HealthNet is going to be a personalized health information. You want to be able to retrieve that too, to be able to mix it, right? And then you plug in a set of gateway and you present it to as a universal data model. Now, the universal data model is not good enough either. It needs to be presented up here as a push notification. I want to be notified. I want to push. I want to turn healthcare into active mode. Okay, that push notification has to be there also. Okay, and then the last piece is, since this is a platform, we want to write a set application to prove how the application works. But we know that we're not going to write all of them. So what we do, we open this interface so that third party can come in and write that application. Now, the nice thing about it is they don't have to worry about connecting to different data sources. I'll take care of that. It's called the dirty work, write a set of library that we built in. Okay? You don't have to worry about go in and get a rule engine and things like that. It's all configurable table. You can use that and change that setup so that you can use it for diabetes disease control. That you have to have a different alert going to the iPad and iPhone differently. Okay? And then because you do this, you can work against any data source. And your application, whether you have prototype or innovative idea and things like that, you don't have to worry about, say, I have to worry about dealing with Epic, Cerner, and everything. The information gets to you the same way, and then going to go back to the EMR the same way. Okay? How do we really do it? It's going to be a lot of different, I'm going to go very quickly to the step that we have to do. Open Vista, MUM database in the back. How do we do it? We tap into the RPC between the terminal and the backend database, and we wrap into Java, and we expose the information as a data extraction to our gateway. OScript, professional EMR, or the traditional classic OScript have a different interface. They run on IIS, but they have a Unity interface that we extract different than the OScript Sunrise. Okay? Cerner have minimum object. Backend database is Oracle. You can know that it's different database source, and then it goes through the web services here. They call things differently, but we map it and we make sure that everything goes convert. Epic. Epic has a lot of flexibility in configuration. They allow you to go there, and in between here, there is a component named Chronicle that is MUM's database retrieval. We go in there, we wrote that function to retrieve the exact data we want. We wrapped around with the interconnect, and we expose by a SOAP. This whole, the reason is different color because we have to go in here and creating a customized web service set for us. And when we have this thing, it's exposed to this patient clarity with the same format of data. And then there you go, we expose the SDK along for our care provider. Now, the whole thing about it is this SDK, we're going to open for third party. We're not going to go and say, this is Zoeticx. Go write it. Okay? And then the other second piece, we can open the SDK in the back too. Here's why. This is only 5 EMR. There's going to be a gazillion of things out there. Go and take this SDK and the data model and plug it in. Because that's how I want to see the healthcare change. Because we're not going to be writing all this application. Neither we're going to be writing all this gateway. We want to open that thing so that both ends of the highway is connected. Okay? just one thing that I just alluded is the dynamic medical messaging system is we embed in there is ability to evaluating the medical conditions and target alert to different care provider by role, by shift, okay? And then if there's a shift change, it basically follow and change to the next notification to the new doctor or the new member of that shift. Okay? And that is the second piece of it is the message infrastructure. So to sum up, what we want to do is turn in the passive clinical data into an active environment focused on medical information, and then make sure that the medical information get into the care provider, to the right care provider at the right time for the treatment. We want to be able to open our platform for third party so that a lot of people can come in and innovate without the cost of dealing with the infrastructure of IT, health, EMR, infrastructure in the back end. We're going to take that away, and we're going to embed it and say that we're even looking at embedding future data application server that allow you to set a pattern of trends on a given patient condition so that you can raising a notification based on that. So we take away all these ugly things in the back and build the engine ready so that you can build a car a lot faster and the way that you want to build it. Okay? And that's how our vision of Zoeticx is be able to say, I want to bring healthcare to IT, IT to healthcare based on that. For that, I'm open for questions. I'm right on time. And sorry, I'm more than happy to go in WebEx with you guys later on to show the actual demo. Okay? Yes.
I'm curious, is your platform API currently open, or do you have a timeline for doing that?
We are currently open. Okay. You want to work and jump onto that tomorrow? I give you the API. And actually, I'm nice enough to give you the cloud service in San Jose for you to use it. You don't have to buy your own server and install yourself.
I guess to add on to that, is the cloud server currently connected to real patient data or just sandbox patient data?
Right now, we have only 2 sandbox. Actually, we have 4 sandbox. One is the actual open Vista, which is an open source thing that we download from the Vista world. Oshera is going to be the next one. We have OScript is nice. We are a partner of OScript, so they actually give us the real EMR for the Sunrise that we have in our server on our cloud farm there. And then they give us 2 sandbox. One is for the professional and enterprise, which is a traditional OScript EMR. Okay, we are working on getting with Cerner, and we are counting on working with Oregon Health and Science University on the Epic side. Did I answer your question?
Yeah, so it's all test data.
Yes, sir.
So you said that you download the data for the patient into the application for browsing and viewing. What happens if new data occurs on that patient? How does like a new lab test is posted or something? How does your architecture handle that?
You can enter the data via our dashboard, depend on the EMR that support the right function. Okay, via that interface. So let me answer you very specifically. OScript Helios doesn't have a right function for us right now. The next release they do. Okay, we can do that with OpenVista. We can do that with enterprise professional server for OScript. Okay, we can do that with Cerner. So the data, you can enter the lab result or even vital sign information to this. Okay? There's 2 ways you do it. Yeah. You double tap on the vital sign information area. It brings you to. Let me get the things up and then I'll show you. I double tap it. I can decide, I can enter this data, and it go directly right in back to the EMR. Okay, I can change, just like I'm saying, the threshold and level of notification right there for that patient only. And by the way, we have the nuance integration too. When we turn on the nuance, you can say set temperature 60. Done. Then it takes the command, it goes directly to the back-end cloud server that we have, and we write to the EMR.
So what about the other direction? Say, the AMR, somebody posts a new lab result in the EMR after you've already loaded the patient and they're looking at the data. How do you update the user who's looking at that data for that patient at that time? Yeah. Is there a refresh?
We have a polling mechanism in the back to detect new information, and the polling is not for you to display data, it's for evaluation of the watch list. The watch list, okay? But because the moment that you log in, the time that you log in, we actually go real live to pull that data at that time. Okay, there's no refresh at that time on the ground, because at that time you get the information at the most up to date at that moment. Okay, the polling mechanism, in case that we don't have the right function to that EMR, is for the people to enter the data into the EMR, like a vital sign, something like that, for us to say, here is the new data, evaluate based on the watch list. Answer your question? Yeah. Yes.
Discussion we had in the ICU, somebody might be looking at data, writing a note for an hour, and if they're looking at that, a lot can happen in ICU in an hour. If they're looking at that and it hasn't updated, then there might be new data that they're not.
We can set the polling as, and the nice thing about this is, as much as data that you say 1,300 data point per day per patient or something like that, is not deadly as the AT&T system for revenue billing that have 30 million transactions per day. So the capability of polling and all those things is be able to address that almost. I'm not saying in real time, because real time to me means differently. Real time to me means milliseconds. I'm talking about near time, so within the 5-minute time frame you can set up. Okay, and we can talk about more. No question. Quiet. Yes.
Does your platform offer any way for allowing clinicians to manage the complexity of data across different systems, aside from just showing them or allowing them to access records from different systems at a time? Because you're giving them data not just from their location but from a bunch of other hospitals simultaneously. So
yes.
I'm wondering how your tool helps them manage that.
Okay, so I'm gonna answer you straightforward right now. The right capability that we have is only with vital signs, hemodynamics, and notes and documentation. Okay. The next phase we are doing is the right capability on medical order. However, I put a caveat. We're gonna start with all medical order except for drugs, because drugs, and I can tell you, is the drugs, the EMR have it now. They check that drug against allergy and everything big time, and I'm not in the position to first of all, we're not here to replicate everything that EMR is doing. We are looking for complement that. Okay, so I haven't find a way to put the medical order in drugs and take the advantage of that, because all the EMR behave differently on that department, and I have not worked on that out yet. But the goal is to be able to write it back as much as possible and addressing the most frequent activity that care provider have. That's why we pick the vital and hemodynamics beside that. It's easier every day, every hour in the ICU as an example. Okay? And probably the question that you ask and say, why just iOS, Apple devices? Not because that I like Apple devices. It is, we start that because of the control environment of Apple in terms of distribution and everything, and it's not open source. So that's number one. Number two, I forgot to say, you can go to App Store and download this for demo. However, in order to access the thing, you have to register the device to the server. If somehow, say, you lost the device, we go to the server and we remove the device. Even you have the password of the clinicians, you can't access it. And then there is no data on the patient on the mobile devices. Yes?
I'm just curious. First of all, these are very interesting use cases, and I like the graphical display and everything. But why the ICU? Why, if you're going to look at a situation where you have collaboration, the ICU has probably got the closest proximity. Very often the best results in an ICU are when the docs and nurses can look at each other. Why put in the mobile output here rather than the cases like community days where I think we have more of a need?
Okay, so let me share you how we start Zoeticx, okay? So I told you that I'm not a doctor, so our medical advisor, which one of the medical advisors, Dr. Howard Newman, he's the head of ICU at Case Western at that time. So he made me sit in the ICU for a whole week looking at that. But the truth about why we started in ICU was I want to tackle the most difficult, the most complex, and the data the most active. That's how we do it, okay? Then,
back on you here.
Huh?
ICU, you've got the patient there.
the what I'm saying?
The ICU, you've got the patient right there in front of you.
Yes,
They're not going anywhere.
yeah.
That's actually simpler than the patient who goes to your ED and then goes to a clinic down the street and was discharged from the hospital yesterday. And he's got 3 different sites.
Yes, we start at the ICU. We solve in the ICU, but it's not going to stop at the ICU. That's number one. Number two, and going back to the point I'm making, the goal for us is to make the data and information available. You see the dashboard and application ICU. You know what? We can work on dealing with the emergency, the discharge report. We're working in a hospital to work on the discharge report too. Okay. The other piece that I will show you is also we're working with a startup company who is having a personalized video on discharge report. So they take the discharge report, which we retrieve and we decode for them, to decoding the medical order and things like that, and they generating the personalizing instruction on video and deliver to that patient. So I'm going back to the root of Zoeticx. Zoeticx is not going to solving every problem. We should start at care intelligence is target ICU, but you know what? The data is there. You can tune that thing down. The information, the capability to retrieve data information is there. You can present it differently, and you can go to different platforms you want.
And the one thing I would say, as someone who is both an ICU doctor and a clinic doctor and worked in emergency rooms and does all this stuff, what you realize is you're absolutely correct. The ICU is an environment where everyone is together and the patient is there. However, the reality is that about 95% of ICUs do not have physicians in-house overnight. So what you also talk about is that for an environment which has 24-hour a day, 7-day-a-week care, a lot of that care is still remote by the clinical decision makers. That's point number one. Point number two is that any environment, most of the bad patient outcomes that we have due to cognitive errors and problems with data processing on the other parts of the general medical ward are the same informatics or clinical data retrieval skills that are needed in the ICU as well. Meaning that if you can get complex data presentation right on the ICU patient, the suggestion is, and probably the reality is that you'll be able to get it on the less complex patient. Working up the scale is where the problem is that the reason most EMRs have failed in ICUs or have had problems in ICUs is that the system is optimized for a less complex data source. What I can tell you, and again, if I'm allowed to share, Tan and Terry, is we've actually used our ICU test cases that we built in Epic and put one of them into Zoeticx as well to see the comparison between the two systems as well. So that's the main thing. So yes, the ICU is a closed environment, but most ICU care is done remotely, or at least half the day is. You don't put the catheters in, but yeah, you get a call in the middle of the night and so-and-so is getting worse, someone's not looking, you want to be able to look it up, you have to be able to do that.
Now, the other thing, too, I want to show you is...
Hey, Tan?
Yes.
One,
Go ahead.
to follow up on Jeff's comment, we didn't talk about the remote collaboration, perhaps.
Yes. I'm sorry. let me show you one thing and then. So let's say I am, and by the way, this may not be the scenario, but this is the capability that we have inside Zoeticx. So let me creating a case where this this nurse is at one location and he is. And it doesn't have to be ICU or something like that, but the whole idea is this. I am at the patient bed and I want to have consult with somebody that know more than me, okay? And I will place my dashboard in a certain way. So there's no data right now, but I place the dashboard like this, okay? Because my concern is that time frame with this set of information. So I'm gonna go and say, I'm gonna send a note to Dr. Eric Jones, and whatever it is, you can put the note down and just send it. Okay. Now, you probably hear a lot of things about people talking about the secure SMS messaging. This is secure SMS within the boundary of the cloud, but switch to the so Dr. Eric Jones will get a notification on this one. You see a consultant request. You tap on it. He will drop at the same location as the other one. There's no miscommunication. What Vishnu is trying to tell me is in front of me, and the data is retrieving from the source of the information. But I am present at the same time frame, the same context, like what Vishnu want to see, want me to see. And I can send a reply after I change a different context and put it back. I put it very simple. It's a kind of WebEx for healthcare, but it presents and brings the information at the same context so that there's no miscommunication. You don't have to worry about digging information because it's all in there in that dashboard. Okay? Now, again, this is an example of how you use the message infrastructure and the message system that we built in. It doesn't have to be like that, but that capability is there. Thanks for reminding that.
And just using that example in terms of two different scenarios where you've got an inpatient physician and an outpatient physician, and then they've got questions about something, assuming that they have the capabilities to log in and reach out to that attending physician in terms of why some drug was prescribed. You can see that benefit there in terms of connecting the two dots.
I can show you also in this iPad here that assigned to Dr. Eric Jones. Last night, my engineer has been entering a lot of data that is out of range, and you can see that it beat me all night. Okay. Well, thank you. I'm not a physician, Jeff. That I can run away. But this is the type of notification that is targeted to me, okay? Because you probably also noticed that in here there's a log off and a sign off. A sign off means that I'm signing off the shift. And by the way, you're not allowed to sign off a shift if, say, Jeff not signed into a shift for that patient. So all the time, the concept of Zoeticx is a patient have to have a treating team in the hospital, at least in these cases. So you're going to be, I'm going to force and say, unless Jeff signed in, I can't sign off. And then by that way, when he signed in and then signed off, the next notification on that patient go to him, not to me. No. You can sign me. He has a password, so it's Vishnu. We can do that, Jeff. And by the way, we know the iPad ID that you two have, so we can wake you up. Yes.
So I'm assuming this is not telemetry data, but it is rather, because telemetry data, every time we unplug your monitor, Jeff will be woken up in the middle of the night. So it's got to be coming from actual verified EMR data.
Yeah, verified. We don't, this is what I learned is you have the machine and it feed the data, and only when the care provider will push and say active or authorized, then we pull that up. You're right. Okay.
So I have one comment to add to what Diane said, and that is, as a physician, if I can't find information in the electronic health record, it's because of one of two reasons. Either the information is there in the EHR and I just can't get to it, or the information is not in the EHR at all and it's in some other place, it's in some other EHR. To me as a clinician, I don't care what the reason is, I can't find it. Now one of that I can fix myself. If I'm better at using the system, then I become better at finding the information that's in the electronic health record. Or if the electronic health record is more intuitive and presents the information to me more efficiently, I can find it. But the second problem is an interoperability problem, which is that if it's in a different EHR, there is no amount of training or no amount of way, there's no way that I can improve myself in the system enough to find the information if it simply isn't there. So even though the problem at the surface looks the same, I think the two different solutions to make sure that that information is available to the physician are very different, have very different approaches and very different ways to make sure that it happens. So
yes, exactly. I can attest this thing is Terry doesn't want to call me on days when I tell him that I'm researching old script EMR because I'm going to be in really bad mood. The reason is this, as an example, just like Vishnu is saying, well, you know, the fact is every data is there, right? It's just a matter of turn it on. And then you have to navigate and figure out which configuration you turn it on and which value you turn it on. And then how you're going to put that in graph and view and type just in case of the old script, right? In the case of old script professional, it's a different game, different rule, different set of configuration. And how you're going to go and pull that information out, that data out to turn into information is what we do at the base. Okay? And we want to make that thing available. I want to make that thing available to everybody. We want to open not just the front-end SDK, also the back-end SDK, and use the data model. And by the way, as a note, I'm open to make the data model better, because at the end of the day, I'm not a doctor. Okay, I know how to set up the data model so that it's universal. But you know, you guys can help me. Okay.
It's along that line. We've already taken feedback from Jeff and Vishnu and changed our interface to make it more intuitive.
So
you know, for use by physicians and caregivers.
So as an example, the question, like for example, you know, we have the interface on the iPhone, but you know what? I'm not taking the same 24 hours on the iPhone. It's a much more simpler form factor. And the reason I'm designing this one was basically, and that can change too. I'm saying you're at home, you have dinner with your spouse, and the alert come in, right? You want to have something that you can look and say, I better run and look for something. I'm just creating a scenario. Or I can finish dinner, okay? I want to have the information in here that's on the go. I can say, oh, this is serious, it's not serious. That I can wait for half an hour later on or an hour. So that is also designed to, you know, give back the time to care provider. So remember, Obamacare can put 48 million more people on healthcare. And it takes 12 years to build a doctor. Or I don't know how many years to exactly. You don't build a doctor fast enough.
No.
Okay? And in the end, it's not about the bed in the hospital. It's the staff to staff the hospital bed. And how are you going to go and count that the doctor with that many things to remember? to deal with that patient effectively. Bandwidth, scalability of the system. In this case, the scalability is not about the hardware scalability of hospital or the bed, it's the staff. And how are you going to return that thing? And going back to the BlackBerry, remember, BlackBerry make everybody work harder without even know about it. Right? Blame them. Exactly. And I mean, this mobile device, you thought it was a toy? Guess what? They make you work harder. The email, you can view the presentation on the go. You can work in the airplane. You name it. They string you, but that's where we should think about. I hope there's not too many doctors in the room. We make the doctor work harder without their complaint. Yeah. Thank you.